Welcome back to the Deep Dive. Today we're embarking on a really critical deep dive into two distinct yet often confusing hip conditions.
That's right.
Avascular necrosis, or AVN, and idiopathic transient osteoporosis of the hip, ITOH. This is vital information for both your exams and, your clinical decision-making, especially as you're gearing up for your FRCS or equivalent fellowship exams.
Indeed. Mastering the nuances of these conditions, from their unique pathologies right through to precise diagnostic markers and effective management strategies, it's really key to confident practice.
Yeah.
We'll help you connect those crucial dots today.
And for this deep dive, we're leaning on the comprehensive OrthoMade Simple Notes. You can find them over at mokyingren.sg.
That's right.
They were generously put together by Dr. Mok Ying Ren, who's a sports surgeon from National University Hospital, Singapore.
Our mission today is basically to distill the most important knowledge for you, making sure you're not just informed, but truly well prepared.
Okay, let's start with AVN of the hip then. What are the primary culprits? What are the underlying mechanisms that typically lead to this condition? What are the big hitters we absolutely need to know?
Well, what's really striking here, quite fascinating actually, is that up to 90% of cases are associated with just two major factors: alcohol and steroids.
90%, wow.
Yeah, it's huge. But beyond these, we categorize the causes into, idiopathic, where we just don't find a clear reason, and then secondary causes.
Right.
And understanding both categories is really crucial for getting the complete picture.
Okay, so diving a bit deeper into those secondary causes, how do they break down? It sounds like there's potentially a complex web of factors at play.
Oh, they certainly are complex. We can broadly classify them, though. First, you've got intravascular factors. These directly compromise blood flow within the vessels themselves.
Okay.
So this includes systemic diseases like SLE, systemic lupus erythematosus, which can cause vasculitis, and also issues with venous outflow, leading to increased pressure inside the bone.
Right, the intraosseous pressure.
Exactly. Sickle cell anemia is another critical one. Here you have abnormal red blood cells that physically obstruct the microcirculation. We also see vasculitis from radiation exposure. And then there's hyperlipidemia and alcohol. Both are theorized to elevate lipid levels, which can contribute to microemboli.
Little clots, essentially.
Pretty much. And don't forget caisson's decompression disease, the bends where nitrogen gas bubbles get released and can cause similar blockages.
That's quite a list of pathways disrupting the blood supply.
Yeah.
It really highlights how a systemic issue can manifest in such a, focused and devastating problem like AVN in the hip.
It does.
Beyond those intravascular factors, there are also extravascular causes, right? Things affecting blood flow from outside the vessel.
Exactly. These can be extraosseous, meaning outside the bone itself. Think trauma, disrupting the primary blood supply.
What fractures?
Yeah, common ones like femoral neck fractures, NOF fractures, and talus fractures, where the anatomical blood vessels are just directly torn or compromised. Or they can be intraosseous, a kind of tamponade effect within the bone itself. This is often seen with steroid use. Steroids can lead to fat cell hypertrophy. The fat cells get bigger.
Right.
And that increases the interosseous pressure, compressing the vessels from within.
Okay, that brings us to a really crucial question, one that comes up a lot. How do steroids actually cause AVN? It's such a common association, but understanding the mechanism is key, isn't it?
It really is. And there are two main theories. Firstly, the fat cell hypertrophy theory. So within the bone marrow, fat cells swell up, they increase in size. And in that confined space of the bone, this significantly increases the femoral head pressure.
Right.
This elevated pressure then leads to sinusoidal vascular collapse and, ultimately necrosis. Bone death.
Okay, theory one, and the second.
Secondly, steroids are thought to create an intravascular hyperlipidemic state, basically high lipid levels in the blood. And these high levels contribute to the formation of microemboli, further compromising blood flow. So you see, both pathways ultimately lead to the same devastating outcome of bone death.
So once AVN has sort of taken hold, what's the typical natural progression? And thinking about our residents preparing for exams and, counseling patients, what makes a femoral head more likely to collapse? Prognostication here seems like everything.
Absolutely. This is crucial for both prognostication and patient counseling. A key systematic review by Michael Mont and colleagues found that 59%, nearly 60% of patients with asymptomatic AVN will progress to symptomatic disease.
Wow, even if they feel okay initially.
Exactly. And this progression is almost always due to femoral head collapse.
Okay.
They identify 3 critical risk factors for that progression to collapse that you really must internalize for your exams and practice.
This next point on collapse risk factors sounds absolutely crucial then for counseling patients and nailing those exam questions. What are those 3 non-negotiable takeaways from that work?
Right. First, it's the etiology, the underlying cause. Sickle cell anemia carries the highest risk of collapse, a staggering 73%.
73%.
Yeah. Followed by alcohol at 47%, renal failure at 46%, idiopathic cases where we don't know the cause at 38%, and then steroids at 26%.
Okay.
Interestingly, SLE actually has the lowest risk, down at just 7%.
Huh, that's interesting. Lower than idiopathic.
It is. Second factor, the size of the lesion. Specifically, greater than 25% involvement of the femoral head. Now, it's important to note this particular study used MRI volumetric calculation for this.
Not the Kerbal angles we might think of.
Not for this specific finding in their study, no. They used volumetric calculation, and 25% involvement significantly increases the collapse risk.
Okay, makes sense. Bigger lesion, bigger problem. And the third?
Third is the involvement of the weight-bearing area, particularly the lateral 2/3 of the femoral head. If the lesion is sitting right where the main load goes through, collapse is much more likely.
That makes perfect sense biomechanically. So we've talked about these macroscopic factors leading to AVN. I'm curious, though, at the cellular level, which of these factors do you think most immediately triggers that ischemic cascade? And how quickly does it move into the reparative phase? Can you walk us through the actual pathogenesis connecting these factors to the microscopic changes?
Certainly. The process essentially has 2 main phases. You start with the ischemic phase. Here, the final common pathway is really the presence of microemboli.
Okay.
These lead to stasis. Blood flow slows down or stops, which increases interosseous pressure, further decreases blood flow, and ultimately causes the AVN and subsequent collapse.
Right, the bone dies.
Precisely. Following this, there's a reparative phase. This involves reactive hyperemia, an increase in blood flow around the dead area, and the ingrowth of new vascular tissue. This initiates what we call creeping substitution.
Creeping substitution. Yeah, I remember that term.
Exactly. It's where the body essentially tries to resorb the dead bone and replace it with new, hopefully healthier bone. It's the body's attempt to heal.
And how do those specific causes we discussed, like sickle cell, steroids, alcohol, how do they tie into this ischemic and reparative process? Do they directly cause the microemboli, for instance?
Some do, yes. Sickle cell disease and SLE directly cause microemboli due to the abnormal cells or vasculitis.
Okay.
Steroids and alcohol, as we mentioned, lead to those elevated lipid levels, contributing to the intravascular issues, the hyperlipidemia, and potential microemboli formation.
Right.
The pathogenesis in chronic renal failure is, well, it's arguably less clearly understood, but it's another systemic condition with a high collapse risk, suggesting a complex mix of factors that compromise bone viability.
Got it. A quick but important point for anyone assessing patients. What percentage of AVN cases are bilateral? That seems like it would have pretty significant implications for screening the other hip.
Yeah, absolutely. It's high, up to 80%.
80? Wow.
Yes. So this is a very significant consideration. You always need to check the contralateral hip for early signs of disease. It's a must-do.
Okay, message received. Always check the other side. Now, for diagnosis and staging, classifications are absolutely key, especially for exams. What systems are we primarily using for AVN of the hip that residents really need to master?
The most commonly used system, and the one you'll see most often, is the Steinberg classification. It progresses logically from initial presentation right through to advanced disease, so it's quite comprehensive.
Okay, how does that break down?
It starts at stage 0. X-rays are normal, patient has no pain. Stage 1 is when the MRI becomes positive, even if the X-ray is still clear.
Right, MRI picks it up earlier.
Exactly. Stage 2 shows changes on X-ray, typically increased density or sclerosis in the femoral head. Stage 3 is characterized by the presence of the crescent sign.
Ah, the classic sign.
The classic sign, that thin, lucent line just beneath the subchondral bone. It indicates early subchondral collapse, but critically, without flattening of the femoral head yet.
Okay, and then?
Stage 4 signifies definite flattening of the femoral head. Then stage 5 involves osteoarthritis, but only in the femoral head without acetabular involvement. And finally, stage 6 is full-blown osteoarthritis affecting both the femur and the acetabulum.
That's a clear progression, very useful clinically and for exams. So knowing that Steinberg classification, where does the older FICAT classification fit in? Is it still something we need to be, aware of?
Yeah, it's good to be aware of it. The FICAT classification is primarily an X-ray-based classification. For practical purposes, FICAT stage 3 essentially equates to Steinberg stage 4, so it aligns somewhat.
Okay.
While it's less commonly used for primary staging now compared to Steinberg, you'll still see it referenced in older literature, and it could potentially pop up on exams, so having that general awareness is beneficial.
Right, so knowing if it will collapse is arguably just as important as knowing what stage it is. How do we prognosticate the risk of collapse, especially given these various stages? This feels like where true clinical judgment really comes into play.
You're absolutely right. Predicting collapse is paramount for guiding treatment. Initially, the Kerbal angle was described way back in 1974 using X-ray measurements to try and quantify the necrotic area.
Okay.
However, a key study published in 2006 by Hott and colleagues, based on 37 IPs followed for 3 years, introduced the modified Kerbal angle. And this uses combined necrotic angles measured on mid-coronal and mid-sagittal MRI cuts.
Ah, so they moved to MRI for better detail.
Precisely. Which raises the important question, why the move to MRI? What advantage does it offer over the traditional X-ray for this specific measurement?
Well, MRI offers vastly superior soft tissue contrast and crucially allows for a three-dimensional assessment, I imagine.
Yeah.
So you get a much more precise measurement of the lesion's true size and location, particularly its involvement in that critical weight-bearing area.
Exactly right. MRI provides that crucial volumetric and spatial detail you just can't get from a plain X-ray. And their findings with this modified MRI-based approach were quite striking.
What did they find? What are the key numbers?
They found a strong correlation. If the modified Kerbal angle, the combined angle from coronal and sagittal MRI was less than 190 degrees, there was a low risk of collapse. These hips generally remained non-collapsed.
Okay, low risk below 190.
Correct. For angles between 190 degrees and 240 degrees, there was a moderate risk. About 50% of hips in this range collapsed during their follow-up.
50-50 chance.
Pretty much. And finally, if the angle was greater than 240 degrees, there was a very high risk in their study. All hips in this category collapsed.
All of them, wow.
All of them. So these specific angle thresholds, 190 degrees, 140 degrees, 240 degrees, are a critical exam-ready tool. It gives you a powerful edge in prognostication.
Definitely one to remember.
Okay.
Shifting slightly, what are the absolute telltale signs we should be looking for on imaging, those classic diagnostic clues for AVN that just sort of jump out at you?
On X-ray, as we mentioned, the most classic sign is the crescent sign, that thin, sort of curved, lucent line just beneath the subchondral bone. It screams early collapse. On MRI, the really distinctive sign is the double line sign. It appears as this kind of serpentine, wavy, dark line that's the interface between dead and living bone, which is paralleled by an inner bright line and an outer bright line on T2-weighted images.
Okay, the double line sign on MRI.
Exactly. That's a hallmark of AVN. These are critical diagnostic clues you should immediately recognize when you see them.
Okay, fantastic visual clues there. Now that we've really dug into the diagnosis and prognosis, the natural next step is, of course, treatment. What's our initial game plan for non-operative management? Where do we start before even considering surgery?
Well, going back to that Mont systematic review from 1996, it showed no difference in outcomes based purely on weight-bearing status, whether patients were full weight-bearing as tolerated, partial, or even non-weight-bearing.
So strict NWB isn't necessarily helpful.
The evidence from that review suggested not. So standard non-op management typically involves, first, providing analgesia for pain relief. Second, physical therapy to maintain hip range of motion.
Keep things moving.
Exactly. Third, allowing full weight bearing as tolerated to avoid muscle wasting and deconditioning. And fourth, perhaps considering a reduction in high-impact activities, like running or jumping. The goal really is symptom relief and maintaining function while you observe the natural history.
Okay, makes sense. What about pharmacotherapy? Bisphosphonates always seem to come up in these discussions as a potential option. Are they a reliable tool we should be reaching for?
Yeah, they do come up a lot, but bisphosphonates remain, well, controversial in AVN, and personally, I don't typically recommend them as a primary treatment.
Why is that?
Well, while one group, Agarwal's group, published some studies, it's really important to note these were not randomized controlled trials. They lacked a control group suggesting some clinical improvement and maybe a delay to arthroplasty with 3 years of alendronate.
Okay.
No other robust high-level RCTs have actually confirmed these findings.
Right. The strong evidence just isn't there yet.
Exactly. And this highlights a really critical ethical and clinical dilemma, doesn't it? Without that robust level 1 evidence, what's our duty of care regarding recommending therapies that aren't definitively proven, especially when you're balancing potential unproven benefits against known risks and costs?
That's a really tough spot to be in, especially for residents on the front lines dealing with patients who might be desperate for options. Do you find there's strong patient demand for these types of therapies, maybe fueled by things they read online, even without that solid evidence?
No, absolutely. Patients often come in having researched things, looking for any possible intervention.
Sure.
Managing those expectations, explaining the current state of the evidence or lack thereof is a huge part of patient communication. It requires really careful, nuanced counseling.
Yeah, I can imagine. Okay, so if non-operative isn't enough or for specific stages before collapse happens, what are the hip-preserving surgical options? We really want to avoid joint replacement if possible, right?
Yeah.
Especially in younger patients.
Exactly. Hip preservation is the goal, if feasible. And we have several approaches. Core decompression is probably the most common primary option.
Okay.
And it's often combined with some form of strut grafting, maybe using a vascularized fibular graft or implanting a tantalum rod to provide some structural support to the weakened area.
So how effective is core decompression on its own? And what's the basic rationale behind it? It seems like a pretty fundamental approach trying to address that ischemic core.
Yeah, the rationale is pretty straightforward. A study by Fairbank and colleagues showed varying survival rates depending on the initial severity based on the FICAT staging. FICAT 1 had about a 90% survival rate at their follow-up.
Pretty good.
Yeah. FICAT 2 was down to 66% and FICAT 3 was only 23%. So severity matters a lot. About half the patients progress by at least one stage despite the decompression.
Okay, so not a guaranteed fix, especially in later stages.
Definitely not. The rationale is threefold. 1, to decompress that high intraosseous pressure we talked about. 2, hopefully to increase blood flow into the ischemic area. And 3, to promote a healing response by allowing new vascular ingrowth.
And the procedure itself?
It involves inserting a guide wire into the necrotic area, usually under image guidance, then over-drilling with a reamer to create a channel and sometimes inserting a graft into that channel. Postoperatively, patients typically need partial weight bearing for about 6 weeks. That's key to prevent subtrochanteric fractures.
Right, protect that area while it heals. What about other techniques? Maybe less invasive options or different biomechanical approaches to try and save the hip?
Sure. There's percutaneous drilling. This uses image intensifier guidance to make maybe 2 or 3 passes with a smaller, like 3mm Steinman pin. It's essentially creating smaller channels for revascularization, but with less bone removal than a full core decompression.
Less invasive, potentially.
Potentially. And then you have osteotomies. These aim to change the biomechanics of the hip. They can be either angular, like a transtrochanteric curved varus osteotomy, or an intertrochanteric varus osteotomy.
Shifting the angle.
Exactly. Or they can be rotational, like the Sugioka transtrochanteric rotational osteotomy. The idea here is to rotate the healthy part of the femoral head into the main weight-bearing zone, taking the pressure off the necrotic segment.
Clever. And I remember hearing about something called a trapdoor procedure. That sounds quite involved, presumably for more advanced pre-collapse cases.
Yes, exactly. The trapdoor procedure, described by Mont and colleagues back in 1998, it's definitely more involved. It requires a lateral approach, actually dislocating the hip joint.
Whoa.
Yeah. Then you create a literal trapdoor of bone and cartilage over the lesion, lift it up, debride all the necrotic bone underneath down to healthy bleeding bone. Then you pack it, typically with corticocancellous iliac crest bone graft, and then carefully replace the trapdoor.
So you're cleaning out the dead stuff and replacing it with live bone graft under the cartilage.
Precisely. Mont specifically described using this technique for FICAT stage 3 cases where there was already some collapse but before major head flattening. So, yeah, targeting a more advanced pre-collapse scenario.
Okay. Now, when using grafts, whether it's for core decompression or the trapdoor procedure, what are the potential issues we need to be aware of? Grafts aren't without their own unique set of complications, are they?
You're absolutely right, they're not. For the tantalum rod, for instance, it can sometimes be quite difficult to remove if the patient eventually needs a total hip replacement down the line.
Right, metalwork removal issues.
Yeah. And there have been some concerns about retained tantalum debris potentially affecting wear rates if you convert to a THR, although some studies haven't shown increased wear at shorter follow-ups. Still, it's a consideration.
And the fibular grafts.
For vascularized fibular bone grafts, the donor site complications can be quite significant. Things like great toe flexion contracture that occurs in about 37% of patients.
37%. That's high.
It is surprisingly high. Also, ankle pain, sensory loss around the harvest site, and infection risk. We think the great toe contracture happens because you disrupt muscle origins, leading to a kind of tenodesis effect on the long toe flexors. It can be subtle but bothersome.
Wow.
And then at the graft site itself, in the hip, you can get complications like pin migration if pins were used, heterotopic ossification, extra bone formation, and even fracture through the graft site. So, lots to discuss with the patient beforehand.
Definitely a lot to weigh up.
Oh,
Okay, so when preservation fails, or for those advanced stages, hip replacement becomes the answer. How should we approach total hip replacement in AVN patients? Is it just a straightforward primary case, or does the underlying AVN add specific complexities we need to plan for?
absolutely not straightforward. You should always consider a THR in an AVN patient as a complex primary procedure.
Okay, complex primary. Why?
Yeah. Well, several reasons. Preoperative planning is critical. You absolutely must use templating, paying close attention to any existing leg length discrepancy, which can be common. Get long leg films if needed for accurate measurement. And you should probably plan for using a hybrid implant system, maybe a cemented stem and an uncemented cup, or vice versa, to maximize fixation options given the potentially compromised bone quality.
Right, anticipate fixation challenges.
Exactly. And for specific causes, like sickle cell anemia, it's essential to coordinate with hematology, arrange for potential blood transfusions, and have a cell saver on standby because they can have higher bleeding risks.
Okay, and intraoperatively.
Intraoperatively, be prepared for challenges. You might need a more extensile approach than usual, like an extensile posterior approach. You absolutely must anticipate significant stiffness in the joint.
Right, AVN can make things tight.
Very tight. So you may need to release the psoas tendon, maybe part of the gluteus maximus insertion. You might even need to consider doing an in situ neck cut before you can safely dislocate the hip. And definitely exercise extreme caution during rasping and broaching for the implants. The bone quality can be treacherous, a real mix of very soft, almost mushy areas from bone marrow changes right next to regions of very dense sclerotic bone. It makes achieving stable implant fixation challenging.
Sounds tricky. And post-op, what's the standard protocol for weight bearing after THR in these complex cases?
Usually it's standard full weight bearing as tolerated, just like most primary THRs. The stability comes from the implant fixation achieved during surgery.
Okay. Are there any other specific concerns with sickle cell anemia patients undergoing THR that we haven't touched on yet? It sounds like they present some unique challenges beyond just the intraoperative blood management.
Absolutely. They have well-documented higher risks of complications postoperatively, particularly infection and implant failure or loosening.
Why is that?
Well, that necrotic bone has inherently limited potential for biological bone ingrowth, which is what you rely on for long-term stability with cementless implants.
So cement might be better.
Often, yes. Cemented implants are frequently preferred in sickle cell patients to achieve more durable and immediate fixation, bypassing the need for robust bone ingrowth.
Okay.
Plus, those bone quality challenges we mentioned, the mix of soft areas from marrow hyperplasia and dense sclerotic regions, can lead to eccentric reaming, especially on the cup side, making it really difficult to get good press-fit fixation for a cementless cup. It truly requires meticulous planning and often a pragmatic approach to implant choice, frequently leaning towards cemented options, particularly for the stem, when bone quality is a significant concern.
That's really valuable insight for planning those cases. Just a quick reminder that you're listening to The Deep Dive, and this focused discussion is built upon the invaluable Ortho Made Simple notes from mokyingren.sg. Okay, having thoroughly dissected AVN, it's absolutely critical we now turn our attention to its often confused cousin, idiopathic transient osteoporosis of the hip, or ITH, sometimes called bone marrow edema syndrome, right?
That's right, BMES. And making this distinction is crucial because its natural history is so different from AVN.
So what's fascinating about its presentation? How does it typically show up?
Well, typically, it's progressive atraumatic hip and groin pain. Often without any clear inciting event, it just starts hurting and gets worse.
Okay.
And the demographics are interesting. It usually affects women, particularly in the last trimester of pregnancy, and also middle-aged men. So that patient profile should make you think about ITOH.
Right. Pregnancy in middle-aged men, key demographics. What do the images tell us for ITOH, and crucially, how do they distinctly differ from AVN? What are the key diagnostic findings, and maybe just as importantly, what's not seen that helps differentiate it?
Good question. On X-ray, you might see some localized diffuse osteopenia. The bone might look a bit washed out. But crucially, there's no joint space narrowing, no scalloping of the femoral head, no subchondral collapse, and no fracture line.
So none of the destructive changes of AVN.
Exactly. That absence of structural damage on the X-ray is a key differentiator. The real diagnostic power, though, comes from MRI.
What do we see there?
MRI characteristically shows a widespread heterogeneous bone marrow edema pattern. You see that bright signal on fluid-sensitive sequences throughout the femoral head, maybe extending into the neck.
Lots of edema.
Lots of edema. But critically, without the specific features of AVN, like that distinctive double-line sign or any evidence of a defined necrotic segment or subchondral collapse, it's edema without necrosis.
Okay, edema without necrosis or collapse. That's the key MRI distinction.
Yeah.
So given the similar presentation of hip pain, how do we definitively diagnose ITOH? Especially when we need to confidently rule out other, much more serious conditions that might present similarly, like AVN, infection, or even malignancy. It sounds like it really is a diagnosis of exclusion.
It absolutely is a diagnosis of exclusion. You have to be thorough. When a patient presents with that kind of progressive hip pain, particularly in those demographic groups, you absolutely need to rule out infection, malignancy, and AVN first.
Right.
And this brings up a critical point for you as residents. What tests do you prioritize in that acute or subacute setting to rule out those critical conditions swiftly and accurately? You need to make sure you don't miss something more sinister while considering ITOH.
That's a very practical and critical consideration.
Yeah.
So beyond just the imaging, are there specific lab markers or maybe clinical signs that help us confidently rule out those differentials, especially infection and malignancy?
Yes, definitely. For infection, you'll absolutely want inflammatory markers, ESR and CRP. If they're significantly elevated, infection moves way up the list.
Right.
And if there's any suggestion of an effusion on imaging or clinically, then a synovial fluid aspiration for cell count, gram stain, and culture is essential.
Okay, labs and maybe aspiration for infection. What about malignancy?
For malignancy, a really comprehensive history looking for constitutional symptoms is vital. Unexplained weight loss, drenching night sweats, persistent fever, history of prior cancer.
Red flags.
Exactly, red flags. And if the imaging has any suspicious features, maybe cortical destruction, a soft tissue mass, then further investigation, potentially including a biopsy, might be necessary.
Okay. And differentiating from AVN really comes down to that MRI again.
Primarily, yes. While the clinical picture can overlap, the MRI is key. For AVN, you're looking for those specific signs, the double line sign, evidence of subchondral collapse, even if subtle, like the crescent sign. For ITH, you're looking for the absence of those signs, coupled with that diffuse bone marrow edema. It's really about recognizing the specific patterns, or lack thereof. You're looking for what isn't there just as much as what is.
That makes sense. Looking for what's not there. So once you've excluded the bad stuff and you've arrived at a diagnosis of ITOH, how is it managed? What's the treatment plan, knowing its transient nature, and what can patients expect?
The good news is that management is entirely non-operative. The primary recommendation is protected weight bearing, often crutches, mainly to avoid any potential stress fractures in that weakened osteoporotic bone.
Okay, PWB.
Yeah, protected weight bearing. But crucially, the condition resolves spontaneously. It just gets better on its own.
Really? How long does that usually take?
Typically, symptoms and the MRI changes resolve completely within about 6 to 8 months, sometimes up to a year, but without any need for surgery or other aggressive interventions.
Wow.
So a huge part of the management is actually patient reassurance, explaining the benign, self-limiting nature of the condition, that it will get better.
That's a stark contrast to AVN.
Yeah.
Fantastic. Well, that was an incredibly thorough exploration of both AVN and ITOH. Wow. From the granular details of pathogenesis right through to the specific nuances of surgical approaches and, importantly, those crucial distinctions for diagnosis. We've covered a lot of ground.
We have.
For those of you preparing for your exams, really understanding those classifications like Steinberg, the prognostic indicators like the modified Kerbal angle, and the specific concerns with different patient populations like sickle cell anemia or pregnancy for ITOH, that's absolutely paramount.
Absolutely. And remembering that key takeaway for ITOH, it's a diagnosis of exclusion. It has that spontaneous resolution that helps prevent unnecessary and potentially harmful intervention. Knowing what not to do is often just as important as knowing what to do, especially in the context of these challenging hip conditions and your exam preparations.
Couldn't agree more. So here's a final provocative thought for you all to mull over as you continue studying. Given the prevalence of AVN and how varied its presentation can be, how might identifying early, perhaps subtle findings on routine imaging, maybe even incidental findings, change our current approach to patient education and prevention, particularly for those patients with modifiable risk factors like alcohol use or steroid exposure? Could we potentially intervene much earlier and truly change the natural history for more patients? Something to think about. That's all for this deep dive. A huge thank you once again to Dr. Mok Ying Ren and his fantastic OrthoMade Simple notes from mokyingren.sg, which formed the backbone of our discussion today. You've been listening to The Deep Dive.
And as you continue on your journey through residency, exams, and beyond, remember this encouragement. No one is established by wickedness, but the root of the righteous will never be moved. That's from Proverbs 12, verse 3. Stay rooted in your commitment to learning and to serving your patients.
Until next time, keep digging deeper.